So Shubha will be presenting a rare presentation of choristoma as a caruncular mass.
Are the presentations of other speakers loaded? Better to load, na? Otherwise
Next one is also use old laptop.
Format is changing.
Is it right on this his laptop? So if you have on the pen drive, you can use his laptop. Even on his laptop, it won't.
All of you can visualize this pink looking or a reddish stone on your screen. Can anybody take a guess as to what this can be? We agree, or we might all have a mental consensus at least to say that this is kind of a precious stone. This is actually a red carbuncle. However, when we have an eye for such a precious stone, why don't we have an eye for this? Why don't we look at what is pink in our OPD clinics? And what if the pink is the new gold, or the new platinum, or the new diamond? What we often know from the literature is that caruncular lesions are extremely rare, with about 0.3 to 1.1% of the total surface lesions, with majority of them being benign, and most of the series report that nevus from a caruncle is the most common lesion. And because of its rarity in presentation, it is difficult to diagnose and treat. So today we look at one such less frequent case in our OPD, which walks in, and this is titled the choristoma. We have a 32-year-old young lady who presented to us with a lesion at the inner angle of the eye, or the middle canthus, which was there since the last 22 years but bothered her to come to us since the last 1 year, since it was painless and progressive. What we do best at our clinics is have a focused case-based approach and have a detailed eye for a slit lamp evaluation, which shows in this case a fleshy pink non-pigmented mass of the dimensions as mentioned, with the posterior border not so discernible, which is not tender, soft to firm in consistency with no fixicity to the sclera, and no prominence on Q-tip pressure. However, what is interesting to note is that there is a yellowish hue inferiorly, if you may see and appreciate, and there are cilia through the lesion, giving it a hint, and with no other puncture not being involved, ruling out possible lacrimal involvement. And our differential diagnosis in this case were a choristoma, or a sebaceous gland neoplasm, or a papilloma. So what best is provisional diagnosis, or the working diagnosis definitely helps in having a mental workup before you go and take the patient on surgery. However, what's most important is the definitive diagnosis, which is always on histopathology. So what best is to put the lumbricals of the expert to work, and the operating surgeon is Dr. Subhav here, where we went ahead with a complete excision of the mass using a monopolar radiofrequency electrode, followed by a pedicle excision of the same mass using a bipolar electrode to minimize the bleeding associated with it, and later reconstructing the surface with glue. And on subsequent histopathological examination, what you might appreciate on the screen on the left hand side is a gross specimen photograph showing a fibrofatty tissue with a keratinized skin surface and cilia projecting through the surface of the lesion, and on the right hand side is the photomicrograph, which shows presence of keratin pearls and other elements, and also glandular tissue, making us realize that it is two different histological subtypes that we see on this photomicrograph. And moving on to what this can be, let us just employ the 5 men which we know to learn new things in our OPD. What is it? It is a presence of a normal tissue at an abnormal location, and who constitute as a family to this lesion would be two different tissue types, making it a complex choristoma. If there was a single tissue type, it would have been a simple choristoma. Why is it important is, one, we look at the systemic associations with it, that is nevus sebaceous, Goldenhar syndrome, Klippel-Feil syndrome, and the encephalocranial involvement. And what has been always spoken about is the classification of these lesions and the presence of these on the epibulbar surface. However, what has been really rare is the involvement of the caruncle, with one such being reported in a 3-year-old girl, and we report such a case in a 34-year-old female. What is important that we have an eye and attention to detail on a slit lamp, a complete excision followed by histopathological confirmation, and then a window to the system examination where and when necessary. Thank you.
Thank you, Subham. This simply suggests that even simple looking lesions could be taken into a deep dive, and you may have surprises. Right? Thank you. Can we have next speaker if we don't want to discuss it further? And please be ready. Do you want to have some comment or something?
Yeah,
By the time-
so Shubha, how did you ensure that this is not going into the medial rectus or the medial orbit? So clinically, if you can just give the pointers.
Ocular motility limitation was not there on our examination. Second is when we put a positive pressure on the globe, the prominence of that indicates that possibly it is not invading the organ. So both of them are clinical pointers to what is there.
Correct. So if any of these were there, you would have gone ahead and done a orbital imaging.
Imaging.
Yeah. Thank you, Shubha.